My name is Dr. John Beronio. I am part of Valley Medical Group, and as of now, my office is at 171 Franklin Avenue in Waldwick, New Jersey. And today we're here to talk about just basic common foot problems and treatments. I'm sure that everyone here has had their fair share of foot ailments, so we'll go over some basic foot ailments that most people encounter daily. First thing we'll talk about are bunions and hammertoes. If you've ever taken a look at your foot, or you've taken some shoes off and see this big bump on the side of your big toe, and it's red and painful after wearing shoes, then most likely you have a bunion. And if you've ever looked at any of your little toes and have seen, like a little corn on top where the toe is sticking up instead of laying flat, that's what's called a hammer toe. So bunions and hammer toes are pretty much our bread and butter. We see a lot of them and treat them in multiple types of ways, either surgically or conservatively. So first we'll talk about how you get them. The etiology of bunions is mostly hereditary. If you do have bunions or hammer toes, if you look into your family history, you will find someone more likely than not that does have, these deformities. Shoes can cause a deformity, but most likely shoes will cause the pain from the deformity, meaning that you have the deformity, you have a bunion or the hammer toe, and if you were to walk barefoot, or if you were to walk in sandals, you would never have any pain with it. But once you put shoes on, then they'll start to hurt. So a lot of people think that their shoes, or women would think that their dress shoes cause the deformity, but that's not necessarily the case. The case is that you have the deformity, but then the shoes cause it. Injuries or trauma, they can also cause these types of deformities. If you injure your foot, you can tear or rip something within the soft tissue within the foot, which would then cause the first metatarsal, which is what the bunion is caused by, to move, or to cause those toes to cock up and become hammer toes. And same thing with intrauterine deformities. You can have these bunions caused by your intrauterine pressure or the intrauterine position, at birth. So the way we treat bunions is one of two ways: conservative treatment, and that consists of basically accommodating for the deformity, not really fixing it or straightening out the toe, but you want to wear a wider, softer shoe just to allow for it. Again, because the pressure from the shoe is what's going to cause the pain. So if you have a wider shoe, or you take your shoe to be stretched by a shoemaker, it'll accommodate the deformity, make you feel better. You could put some padding in the shoe to kind of just pad off that bump of the bunion that causes a lot of pain. Or you also try non-steroidal anti-inflammatory drugs like Motrin, Tylenol, or prescription NSAID to help with the pain. And emollient therapy. Emollient therapy meaning like just some lotions to kind of reduce some of the friction around the bunion, which would cause the pain. Okay. The next way to treat the bunion is surgical treatment. And surgical treatment, you can do a couple of different ways, and it is determined by the severity of the deformity. And the severity of the deformity is measured by the angle between the first and the second metatarsal. And let's see here, I'll show you. This here is the first metatarsal, and this is the second metatarsal. So the angle between these two bones determines the severity of the deformity, and the severity of the deformity will determine the procedure. Sometimes, though, people would just want to have that big bump removed. And the bump is what's causing pain, and in an older patient where you don't want to have an osteotomy, which is cutting the bone and shifting it, moving it, you just want to get rid of that bump. It buys you a lot of time, excuse me, and that's a very viable option for an elderly patient. An osteotomy, as I just explained, is where we cut that first metatarsal, shift it, and move it. A fusion is when we would fuse the metatarsal here as well as that big toe joint. So this would be straight, like these two bones here would then become one. So they would be fused. And then a newer type of procedure that we do here at Valley is what's called the lapiplasty. The lapiplasty is this procedure here, where a cut is made in the bone here, where these two bones here, this bone and this bone, are then fused. You're able to move this first metatarsal towards the second to make it straight, and then it's held together by a couple screws that are attached to plates. So you can see how this started here and turns into this. And then this is the final product on a real foot, where this was the foot prior to the surgery, and this is the foot after the surgery. So it's a small little incision here, little incision here, here, and then the bigger incision where all the work is done is right here. Okay. Now our next common ailment that we see, and this is probably about 50 to 60% of the patients that we see, especially in the summer, is what's called plantar fasciitis. If you've ever woken up in the morning, put your foot down, go to step to go to the bathroom, and felt a stabbing pain within your heel, most likely you have plantar fasciitis. The plantar fascia is a band of tissue connecting your heel. I'll show you a picture over here. Connecting your heel to your toes. And when this band of tissue becomes inflamed and from being stretched, that's what plantar fasciitis is. So the symptoms of plantar fasciitis are a morning pain, as I said, or pain after, if you're sitting watching TV for a half hour, if you're driving for a little bit, you get that pain in that heel as soon as you step down on it. And again, it's a sharp stabbing pain. It's like having a toothache in your heel. And you also will experience some arch pain as well, because that plantar fascia does start on the bone and go up to the toe. So you'll feel that pain in the heel. As you can see here, this is, sometimes you'll feel the pain right up on here. So the causes of heel pain. Heel pain is really due to support or lack thereof. That's why we see a lot of this in the summer months, where a lot of people are either walking around in sandals, barefoot, flip-flops. Flip-flops are a big cause of heel pain in the summer. Again, poor shoes, meaning that shoes that don't, if you look at your sneakers or shoes and you don't have any support on the bottom of the shoe, and I'm talking about on the inside of the shoe, not on the bottom outside of the shoe. If that inside bottom of that shoe is flat, there's not any support in the arch. What you do is you need to have some support in that arch to push up against it to take away the stretching of that plantar fascia. And also trauma. A lot of times if someone running or step on a rock or something like that, that would cause inflammation around the plantar fascia, that's, excuse me, that's another cause of the plantar fasciitis. So if you do get this heel pain, what do you do for it? First, you come in to see me, but then I'll tell you what to do. So treatments for the plantar fasciitis is RICE. RICE stands for rest, ice, compression, and elevation. So you want to ice it. I think a good way to ice the heel and the foot for plantar fasciitis is a water bottle. Freeze a water bottle, and once it's frozen, you can take it out and roll that water bottle over your foot. So you're both stretching it and icing it at the same time. If you were to come into my office, you'd get a strapping. A strapping is just that. It's a taping of the foot, which will provide a good deal of support for the plantar fascia so it doesn't stretch. Orthotics. Orthotics are inserts that go into your shoe. They're either over the counter or custom made, as we do here in the office. And what they do is they are support devices for your foot to take away that stretching of the plantar fascia. Physical therapy. If you've had plantar fasciitis for long enough where the strapping and the orthotics and the injections that we'll talk about have failed to relieve your symptoms, then physical therapy, where the therapist will go in and do some massage therapy, they'll do some ultrasound, they'll do some heat, some ice. And then finally is corticosteroid injections. They are one of the more effective ways to treat the plantar fasciitis, except that it can be painful. So a lot of people would like to either try an oral steroid or an oral anti-inflammatory, or go right to an injection. And if in the right hands, that injection is not too painful. And then your surgical treatment of the plantar fascia is what's called an endoscopic plantar fasciotomy. This is a procedure that's done in the hospital or in a surgical center, that's done under local with IV sedation, where, and I'll get back to this little band here, a small incision is made on the side of the heel, and an arthroscope is put through the foot, where this part of the plantar fascia is just cut away from the bone. And when you cut it away from the bone, you then eliminate that pulling of the plantar fascia on the bone, which will alleviate the pain. Now, with an endoscopic plantar fasciotomy, say it was done on a Friday, you would have a big bulky dressing on over the weekend, and then Monday, over each incision, the bandage is changed, and then a Band-Aid is put over each incision, and then you're back in sneakers. So surgery's on Friday, you're back into your sneaker on a Monday. But that is always the last resort of treatment. I mean, you really have to go through the gamut of all the other types of treatments before you consider the surgical treatment. And another common ailment that we see here in the office is what are called plantar warts. If you have ever felt like you had a pebble in your shoe and you don't have a pebble in your shoe, and you look down and you have this big callus on your foot with a couple black dots in the middle of that callus, most likely that's a wart. And a wart is a wart. There's no difference between a wart on the top of your foot or a plantar wart. The top of your foot is called the dorsal surface of your foot, and the bottom of your foot is called the plantar surface. So if someone says you have a plantar wart, it's just describing the location of the wart, not the type of wart. So I said, these warts are hard, grainy growths that appear on the foot. Depending on where they are, it can be painful. And like I said, it is like walking on a rock. They're caused by the human papillomavirus. And the way you contract these, you can contract them in many different ways, but usually it's when you're walking somewhere barefoot, somewhere in public, like a gym, a locker room in the gym, the pool, at your local Y. I mean, the Ridgewood and the Wyckoff Y kind of keeps me business during the winter with kids getting these warts. At a hotel, in a shower, that's why you do want to kind of wear, or a locker room, so you want to wear shower shoes when you're in a hotel or in the locker room at your local gym. So if you get these warts, how do you treat them? Well, the conservative way to treat them is through biweekly debridements, where we remove all that dead skin around it, and you get down to just what's called pinpoint bleeding, and that's the virus itself feeds off of the small blood vessels on the skin. So when you get down to that pinpoint bleeding, then we're treating the wart itself, the virus itself. And you either apply an acid, which is called phenol, or we use almost like a liquid nitrogen type of spray, a cold spray, to treat them. And then you can also treat them at home with what's called compound W, which is basically just a weaker form of salicylic acid. And then there are patients where warts can be real stubborn, and these treatments don't really help, where we have to just do it in the office, where we just numb up the area and cut the wart out, and then we'll cauterize that area, kind of burn the skin around the area, around the wart, so we make sure that we kill the whole wart itself. The only problem with the surgical excision is obviously if you have, and you're cutting something out of the body, you're leaving a hole in where the wart was. So it takes a while for that hole to fill in. And what you don't want to do is to really do a lot of walking, depending on where it is. You don't want to do a lot of walking on it, because that can cause scar tissue. And the scar tissue, if that fills in with scar tissue, then that's more painful than the original wart itself, the original problem. So the fix is worse than the problem itself. The other things we deal with are different types of sports injuries. Pickleball is a growing and very popular sport, especially among the elderly or the older population around here now, and we're starting to see a lot of pickleball injuries. What we'll see are basically sprains and strains, ankle sprains especially. If you've ever rolled your ankle where you're on the outside of your ankle here, there is a ligament that starts here and goes over to here that prevents your ankle from doing that. So when you sprain your ankle, you're either stretching that ligament or tearing it. Like I said, usually it's on the lateral side, which is on the side of your little toe. It's painful to walk afterwards. A lot of times it will require some crutches and ice elevation, and you're out of commission for a little bit. Again, the treatment of sprains, and you can see here how swollen the ankle is, and the black and blue. When you have this type of black and blue, that would tell me that that ligament, that goes from here to here, preventing your ankle from turning in. With that type of black and blue, that tells me that most likely that ligament is torn. And the only way you can tell that is with an MRI. But to treat an ankle sprain, again, is rest, ice, compression, and elevation. Immobilization, we would usually, something like this, we would put into a soft cast and have you on crutches, so it's immobilized that way. And then once the swelling goes down and weight bearing is tolerated, we send you for physical therapy. And another injury that we're seeing in pickleball especially is fractures. And fractures are just that, they're trauma related. It's a break of the bone. Usually always trauma, not always, but usually trauma related, and usually from a fall. This particular fracture, which is the most common fracture in the foot, is what's called the Jones fracture. So this is the 5th metatarsal here, and at the base of the bone, this fracture here, this little line there, is what's called the Jones fracture. The way you get that is pickleball is a common cause of it, because you're starting, and your ankle will turn a little bit. So instead of that ligament tearing, the bone will break. Or if you've ever stepped off a curb, you can step off a curb kind of funny, and a lot of times that bone will break that way. The way that's treated again is, with immobilization or casting or a cam walker. So here's a cast, a patient able to walk with a cast, or a cam walker is basically, it's like a removable cast. So this is like a big ski boot, and you can take this on and off. You can take it on and off to sleep. You can take it on and off to shower. Sometimes on a fracture, especially like this, it would require surgery, where you would have either put a plate over this with some screws, or just one big screw going from here up the bone here to provide compression so the bone heals properly. Jones fractures are a tough fracture to heal, in that the blood supply to that area of the bone is not great, and lack of blood supply, it makes it harder for the bone to heal. And then finally, we got your foot and diabetes. I know as we get older, tend to become, what are called type 2 diabetics, which are non-insulin dependent diabetics. And there are certain inherent risks and inherent complications with the foot and diabetes. The two main risks are neuropathy, which is loss of sensation, and angiopathy, which is loss of circulation. And if you have the neuropathy, which again is loss of sensation, then you're more prone to what are called ulcers. Ulcers are these little holes within pressure points of the foot. So with your foot and diabetes, prevention is the key. So you need to, A, watch your sugar. Sugar control is the key. You want to keep your A1C, your HbA1c under 7. Under 6 is great, but if you can keep it between 6 and 7, you're much better off. And also, as a diabetic, you want to periodically inspect your feet. See if there are any lesions, if there's any odor coming from your feet, that's a little out of the ordinary. Take a look, use a plastic mirror to take a look at the bottom of your foot, especially if you have neuropathy. Because if you have neuropathy, there are people and there are times where you don't feel your foot at all. So you can be walking on a little thumbtack that's in your shoe. You never know it. I've had patients that have come to me in the summer with burnt feet because they've walked across the beach, the hot sand. Never knew how hot the sand was. Never knew that sand was hot at all. So you want to always take a look at your feet, especially the bottom of your feet, to see if there's anything going on. It's a team approach to the care of the diabetic. So that includes the podiatrist, obviously. It also includes your vascular doctor, because your circulation is the key, and also obviously the endocrinologist who's taking care of the sugar and the diabetes. And that requires regular screening. So you want to see those doctors at least twice a year. A lot of times we will see a diabetic patient, every other month. If they have a fungus in their nails that need to be trimmed, or calluses. A callus in a diabetic foot, if left untreated, can break down the skin underneath and become an ulcer. Let's see. So the complications that can occur with diabetes are infection, hospitalization, and as you see here, amputation. As I said, these ulcers, these calluses can form an ulcer, and if you have poor circulation, you will have a less likely chance of healing anything. Blood carries oxygen, and oxygen is the only way to heal anything. So if you don't have enough oxygen getting down to your foot, you're in much more danger of losing a limb, losing a toe, losing part of your foot. And again, with the neuropathy, if you don't feel it, by the time you do realize that you have an infection going on, a lot of times it's too late, where the infection is in the bone and amputation is then required. So again, it all goes back to the team approach, where everyone's inspecting you, not inspecting you, but everyone's keeping up to date, watching out, making sure that everything is good. I mean, I can go on for hours about the foot and diabetes, but just a overview as to what to look for. So in conclusion, the average person, will take between 3,000 and 5,000 steps per day. And I didn't really do the math, but you figure over the years, that's an awful lot of steps that your body weight is going through your feet. So you need to take care of those feet. As you can see, there are many different types of ailments that can affect you, and early detection and treatment are the keys to healthy, happy feet. So if you ever notice any problems, make sure you see your podiatrist without any problems so you can walk off into the sunset. Thank you.